Good morning. I'm here doing this talk because this is something that has interested me for a number of years, and it just sort of morphed, and it's going to be a topic that you're going to see a lot of, more than you have even in the last couple of years. Now, in keeping with the conference, you'll see in my objectives that intersectionality is all over the place. Mental, physical, psychosocial, symptoms, issues, concerns, time, HIV. So you can see that this is timely. Now, we're talking about age, so I have to know what kind of distribution of age we have in this room. And I'd like to know who is a baby boomer or earlier. And if I don't see a few hands, I'll know everybody's lying. Okay, thank you very much. And you'll see where that comes in a little bit later. We're going to quickly go through these items, and I will try and set the stage for you why the aging is important with HIV, because the numbers are increasing. Today, over 15% of PHAs are over 50, and an interesting fact is the second item there, where the number of people, the percentage of people being diagnosed with HIV over 50 has increased significantly, even by 2003, which is already a long time ago. It's expected that by 2015, the baby boomers will all have turned 50, so that's why I wanted to know that piece. 11% for the first 25 years, 11% of the men diagnosed were over 50 and 1% of the women. Now, AIDS diagnoses per se are decreasing due to antiretroviral therapy, but it doesn't mean people are not seroconverting anymore. With antiretroviral therapy, of course, we have changed age to a chronic manageable disease, but the potential for toxicity also is higher in people over 50. Our bodies don't respond quite as well as when we were younger. And so, particularly with decreases in liver and kidney function, it also impacts medicine dosing. The response to in people with age over 50 to viral load and CD4s is good, and it's very similar to all age groups. However, another thing that's very interesting is that adverse events with medications are least likely to happen in the under 40 and the over 60, which is a very interesting little statistic. One of the things that does happen is that the elders are more likely to be adherent, because they're maybe not partying quite as much. I'm not quite sure why, but I guess we all get a little more set in our ways, and maybe that's what it is. We're going to look at some of these items here and try to relate them individually to aging or HIV. And particularly, we want to recognize what's known there as SNARE, which is a new term which you may be hearing if it catches on. It's significant non-AIDS related events. And the ones that are very important in the over 50 crowd are cancers, non-AIDS related cancers, and cardiovascular, which are highly lifestyle issues. And the other thing to remember is that, like I've heard doctors say before, that everybody with HIV has to have unique and individual treatment programs. Everyone also ages differently, and it has a lot to do with the 50 years that have gone before. In the immune system, first of all, Teresa mentioned Gay Men's Health up north, and she was relating to disclosure. There are studies out there that show disclosing your HIV status is good for your immune system, and disclosing your sexuality is good for your immune system. So I want to give you that news. It's not news, but one of the big things that happens to the immune system as we age is the first line there, which is CD4 senescence. That's aging of the CD4 cells. CD4, and this came out of California a couple of years ago. CD4 cells, like all cells, have a limited number, a finite number of times they can replicate. And because with HIV, the body and the immune system is under constant assault by the virus, the cells are replicating on a whirlwind go. And so what happens, and we don't know yet how much treatment and good adherence affects this, but there will be research coming out on that, I'm pretty sure. But what happens is it's like having two cars bought on the same day. One goes to a person who drives at 10 miles a week, and another goes to a person who drives at 1,000 miles a week. We can all see which one wears out more quickly. And what shows up in people over 50 with HIV is that sometimes their immune system resembles that of someone in their 80s or 90s, because the flagging immune system is a part of aging as well. Cardiovascular, the HIV causes lipid abnormalities, which is really a fancy or a scientific name of saying that it causes a great deal of fluctuation in cholesterol levels. Protease inhibitors increase glucose intolerance, and so predispose one to diabetes, increase the risk of diabetes. And of course, family history is really important. Pre-existing conditions that existed before HIV was contracted are very important because they accelerate. The immune system is less able to keep them under control. And this is a theme, going to be a theme throughout my talk. Lifestyle is critical. For all of us, we know that certain behaviors are not good for your health. Cigarettes are the single worst thing that people can use if they have HIV. They are for everyone, I believe, but they have more impact than in any other lifestyle choice. And there are choices there. And of course, alcohol and obesity and diet are also very important. Substance addictions of any kind are problematic. PHAs going off of heart are more likely to incur heart disease than if you stay on it consistently. So adherence, adherence is very, very important. And of course that has lifestyle implications. Those of you who remember the DAD study, it showed very clearly that the chance of cardiac risk increases 40% for every 5 years of life. So that's pretty significant, and I believe it's worth noting. Then we start talking about hyperlipidemia, which is high cholesterol, LDL cholesterol, and high triglycerides, which of course is all the fats and fatty substances in the blood. It's important here because many of us, HIV positive or negative, have problems with cholesterol. It's important to know for the HIV positive group that some of the meds like Kaletra will interact with statins, which are there to lower your cholesterol levels, like Crestor. And so your doctor needs to be aware of that. You need to talk to them about that. Most people over 50 have some issues of cardiovascular disease, and of course lifestyle comes in there again. We're going to talk very briefly about the skeletal system. Osteopenia is a decreasing bone density. It is a pre-osteoporosis phase, and osteoporosis, of course, is a very low density, and is deterioration of the actual bone tissue, and very hard to recover from. Makes your bones very brittle, as you all know. Risk factors for osteoporosis are first and foremost age, gender, and race. Menopause is a big factor for women. Low testosterone levels in men is important, and it's important to remember that. Medications have impact, chronic illness also does, as well as lifestyle and family history. Osteoporosis, you have some choices around that. Weight-bearing exercise and vegetables, preferably green ones, are your best choices. Tofu is also very good. I didn't put it up there because I know there's a lot of negative reaction to tofu, but if you don't mind eating it, eat it. It's a good source of calcium, which is very good for the bones. And of course, vitamin D. And in Vancouver, that's important in the wintertime because we don't get a whole lot of sun. The liver, the long-term damage to liver is potential is in PHAs over 50 is very high, as ART, and particularly those people who are approaching 15, 20 years on ARTs, many ARTs and other medications such as pain medications are toxic, and are metabolized by the liver and create problems over the long term. And then, of course, any hepatitis is going to really complicate things. So be tested regularly. Cancers. Cancers are the leading cause of death for PHAs, and not necessarily the AIDS-related cancers like KS and non-Hodgkin's lymphoma, cervical cancer and prostate cancer in women and men. And this is very highly related to smoking. So the PSA for men is important, is as important as the pap smear is for women. Hypertension. High blood pressure leads to a higher proclivity towards heart disease and heart problems and attacks. It increases the risk that PHs have, as many, as I've already noted, have factors relating to heart disease, high cholesterol, blocked veins and arteries, or partially blocked veins and arteries, and things like that. And again, lifestyle treatments changes are the best way to deal with that, and possibly a diuretic. Testosterone. Lowering of testosterone, in case you haven't noticed, begins at 40, so give or take a year. And long-term PHAs have lower levels in particularly both men and women. It impacts the skin, it impacts the bones, and it impacts muscles and organs. Some of men's symptoms are loss of muscle mass, as we've all noticed, you know, the disappearing ass, depression, and lower energy. Well, I had to say that because Larry Kramer, the great author of Faggots, always talks about his ass that's disappeared. I'm going to talk very briefly here about HIV in older women. There's a higher risk for HIV infection in older women for a number of reasons. One, they no longer fear pregnancy, so they're not as geared to talking about condoms. They are not as skilled at condom use, insisting on condom use, and they don't believe they're at risk. So there are three factors that women over 50 need to be aware of. Women with HIV have more problems with menopause and irregular cycles leading up to menopause, and menopause may start earlier. And postmenopausal women are also at greater risk for other health symptoms. And the other thing that's very difficult with the people who are newly diagnosed with HIV at the time that they're going through menopause is that the symptoms of HIV and the symptoms of menopause, as they're commonly experienced, overlap. And so often the doctor or the person will not expect to see those symptoms in terms of HIV. Mental health. We've moved into another intersectionality here. Mental health was a big concern in the early days of HIV. For those of you who are around, we called it AIDS-related complex or something like that. I can't even remember the name anymore. But it's becoming back because people are living longer. The brain is affected by the immune system. The lower the CD4 counts, the higher the risk of brain dysfunction. The cognitive symptoms that are obvious, we can equate these with several other dementia processes, such as Alzheimer's, are memory loss, loss of concentration, confusion, apathy. Behavioral symptoms that are really important are depression, changes in sleep and diet. And we don't often associate that consciously with mental health problems, but any changes should be noted. And again, it's hard to distinguish from aging because those kind of changes do happen as you're aging, but they tend to be a little bit later and a little bit slower. Particularly changes in sleep are very common. And motor dysfunction, of course, is really important in mental health because of the changes in the way we walk, the way we can talk, and many other issues. Balance is an important thing. Dementia is caused by brain damage. So how do we have brain damage when we have HIV or any other dementia if we haven't had a car accident or had some significant trauma? Well, what happens is the brain is damaged because cells are dying. And the cells are dying because they are impacted by our whole body system. And what happens is, and I put in there dementis, which is the Latin origin of dementia, and it means literally out of your mind, out of the mind. This slide pretty much continues with what I was already talking about. Personality traits are an important thing. People can become emotional, become more cantankerous. I worked in Alzheimer's for a little while, and I saw people who were very cranky as they got older and had Alzheimer's, and their children or their siblings or their friends didn't recognize the person that was there before, purely from their emotional states. And often depression is an issue there. Risk factors for dementia, HIV related, are known by another new acronym, which is HAND, HIV, AIDS, neurocognitive disorder. So it's a label directly related to HIV. The low CD4 counts, as I've already said, the greater the incidence of dementia. The other risk factors are low body mass index. So if someone is dealing with problems with nutrition, anemia, high levels of drug use or addiction, which affect the body mass, that all puts people at greater risk. Women tend to be at greater risk than men. And of course, age is a factor. Depression is due to changes in the brain chemistry. It's a reduction in serotonin, melatonin, and dopamine, and perhaps a half a dozen others that we haven't identified yet. The lifetime prevalence of depression in people with HIV generally is about 25 to 45% compared to 15% in the population at large. But in older PHAs, it goes up to 52%, with 26% of them seriously depressed. The good news is that it's diagnosable and it can be treated. Causes of depression, of course, living with a disease such as HIV and AIDS is a reason to get depressed, at least initially when you are involved in the shock. It's a possible side effect of antiretrovirals, we don't know that yet, and other medications. Physical disorders help with that or contribute to that. And of course, drug addiction and physical addiction of any kind contributes. The challenges of daily living, which for people with HIV are greater than for the average population. Mobility often becomes an issue, neuropathy, just medication, never being able to go with all of that. And then, of course, family history is a big factor. And as I said earlier, for Teresa, that disclosing raises the immune system. The effects of depression are very important. They can affect adherence. They cause the immune system to go down. They cause an increase in risky sex. And they challenge relationships and increase the possibility of suicide. Stress and depression lead to a faster progression to AIDS from HIV. So that's really important. And again, it's because of the factor that that depression impacts the immune system. And we're not really totally aware yet of how significant that is. Depression is, within one study that I looked at, predicted shorter longevity for people with HIV, and particularly in older men. Let's do another intersectionality shift here. We want to talk a little bit about the psychosocial issues, which are important to people as they age. Important factors are losses. When you have an HIV diagnosis, that's a loss. That's a loss of some of one's potential as you feel about it at the time. Many people do recover from that, but initially those are things that impact us a great deal, and these are ongoing. Often people feel very isolated, and we experience stigma of all kinds. And as we get older, more stigma comes into play. We have the stigma for being queer, we have the stigma for being HIV positive, and now on top of it all, we have the indignity of being old. And it's a real kick in the ass. Self-image, of course, comes right along with that. We don't think our self-image changes, and that's not always something that we're happy about, and often, mostly, we're not. And of course, the effects of HIV for many people is a negative self-image. Our sexuality is impacted by HIV and by age. Declining libido, declining function, a loss of intimate relationships often happens as we lose friends to death or any other reason. And spirituality is another factor that often suffers. I'm ready for you, Trevor. Travis. Psychosocial issues in the community. These are other places where there are problems for people with HIV and AIDS. We don't know which is the main culprit, but they both are at play. Social interactions tend to go down. Peer groups are often reduced. Community involvement is important, staying involved to contribute, to mentor, to volunteer. I was talking to someone yesterday about the possibilities of mentoring and how much we might need that or do need that in our community, and we've got to get to work and set up some kind of those programs to share the wealth that some of the boomers have with the younger crowd. The continuum of care. These are all topics that we've talked about in this whole conference, summit. Housing is a really, really important thing. The work that I do with people in prison makes it very clear that they make it in life or fail when they're released because of housing, and that's important for all of us. And it's very difficult in here, and it adds another social stress. And finances are also very challenging. Looking ahead, we've got a lot of challenges. Housing, I'm going to bring up as the first one. There are no homes for queers, never mind for people with HIV who need assisted living or something like that. The resources that there are in the communities are not ready. In my experience, working a few years ago in many homes with Alzheimer's people, they're not ready for queers. They're definitely not ready for people with HIV because the skills are not there. They have not been moved out of the center of Vancouver into homes. So think about that. Think about somebody here who's got some brilliant ideas and who has got some friends with cash. Set up some homes. It could be a good business. There's not enough research on this area. There's a lot in the pipe, and we hope to it be coming down pretty soon. We need to be innovative in healthcare for this group. This morning I scanned the New York Times online, and I knew I had to do it for a reason. I saw a story there that in Korea, and this is an example of how creative we need to be, school children are being taught about Alzheimer's, the symptoms, how to recognize them, and how to care for people with Alzheimer's. I'm not saying that's our solution. My reason for raising that is it's very creative, it's using the resources that are there, and it possibly has some very, very good results. Thank you very much.